Listen, I've watched this respiratory rate climb into the 50s over this last hour as he was trying to compensate with the bicarb infusion. But now his respiratory rate is down into the 20s, and I fear he's at the end of his ability to compensate, and we need to intubate sooner rather than later. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back. This week is our fourth installment in the 4-part liver failure series. So if you haven't already checked out episode 108 on spontaneous bacterial peritonitis, or 109 on esophageal varices, or 110 on hepatorenal syndrome, definitely give them a listen, as what we're going to talk about today will build on that. But today we're talking about hepatic encephalopathy from cirrhosis, because they often go hand in hand. And I want to just touch a little bit on alcohol withdrawal, even though that topic honestly deserves an entire episode to itself, but it's important to kind of pair with this one too, so let's dive into the case. All right, so I was asked by the nurse to come see a patient for concerns about his mental status. So this was not initially a rapid response. We call these nurse consults at my hospital. When the nurse is concerned, but they don't feel like the vital signs are terrible enough to warrant an entire rapid response activation, where the respiratory therapist and the ICU provider and phlebotomy, the whole crew show up, when they really just want to, quote, put someone on our radar or kind of talk through the case with a rapid response nurse, then they can request the rapid response nurse consult. I love these because I would much rather prevent an emergency than wait till the patient is unstable and try to bring them back from a shock state. So I got the call, and my colleague Marissa and I arrived to find a 40-ish-year-old male, somewhat diaphoretic, and breathing rather fast, though I wouldn't say he was in respiratory distress. He actually appeared to be sleeping. So his vitals were heart rate of 121, blood pressure 130/90, oxygen saturation 99%, but respiratory rate was in the 30s. This patient was only responsive to noxious stimuli, but not really following commands. I would give him like an 8 or 9 on the GCS, 2 for eye-opening, 2 for incomprehensible sounds in the verbal response, like a 4 or 5 on motor response. So I checked to see if he could protect his airway by suctioning out his mouth at the yank hour, and he had a pretty good gag and cough reflex. So Marissa and I talked through the patient's case a bit more with the primary nurse. Now, if he was hemodynamically unstable or not protecting his airway, we would have just called a rapid response and got the provider at the bedside to get orders going stat. But since he had a good blood pressure, he had pretty well-perfused warm skin, he was protecting his airway with a good oxygen saturation, we opted to call the hospitalist and request an ABG to get some more data. So before we did that, we quickly perused the chart to get the rest of the story, review the recent labs and the plan of care, and anything to help build our case, because this particular physician, for whatever reason, is very anti-APG. So I was prepared for that. Here's what we discovered in the chart. So the patient was brought into the ER the day prior by law enforcement, who found him ulcerated in his car on the side of the road. His initial labs showed elevated liver enzymes. His BUN and creatinine were slightly elevated. His CPK was sky high. He had myoglobin in his urine with no red blood cells. His head CT was negative. His urine tox screen was also negative. One of the notes said that he was previously admitted for alcohol intoxication and that he's had several admissions for alcohol withdrawal in the last year. He has a history of cirrhosis, but honestly, we don't know what led up to the law enforcement officer finding him. And without knowing the whole story, this patient had some precipitating event that threw him into rhabdomyolysis, which led to hepatic encephalopathy. He was not drunk, like law enforcement had assumed. His alcohol level was not even elevated when he got to the ER. So he could have been, high the day before on some substance that would have not shown up in the tox screen. Who knows what happened? But here we are now, 24 hours out since he was brought to our ER. So it's not likely that the culprit for his altered mental status was something that he took 24 hours ago. Okay, so now I really wanted the ABG. Why was this young man breathing so fast? And more importantly, why was he so altered? GCS of 9? That is not normal, especially when the tox screen is negative. So we called the hospitalist and shared our concerns about the patient's mental status, respiratory rate, and tachycardia. He felt pretty strongly the patient was just dehydrated and in rhabdomyolysis and assured us that the IV fluids would take care of the symptoms. I reminded him that the patient had been receiving IV fluids since yesterday, and while he may need them, yes, they haven't really moved the needle at all on his symptoms. In fact, he's become more tachycardic and more tachypnic. So he agreed and got the ABG, and boy, am I glad we did. His pH was 7.14. 7.14. His CO2 was 25. His PaO2 was fine at 80. And his bicarb was 11. So we called the intensivist. They accepted the patient and ordered a bicarb drip. Unfortunately, like many hospitals, we're often strapped for beds in the ICU, and they needed to downgrade someone to make a spot. So an hour goes by. I leave to eat lunch, and Marissa stayed to help manage the patient until the ICU bed became available. Then I got a call from the primary nurse saying, Marissa says to come back. He needs to be intubated. So I booked it back to the patient's room. On my way, I ran into one of my favorite respiratory therapists and said, hey, I think I might need you where I'm going. He said, okay, let's do it. So we showed up together to find Marissa on the phone with the intensivist saying, listen, I've watched this respiratory rate climb into the 50s over this last hour as he was trying to compensate with the bicarb infusion. But now his respiratory rate is down into the 20s, and I fear he's at the end of his ability to compensate, and we need to intubate sooner rather than later. She paused while the intensivist responded and then said, okay, thanks. I'll see you soon. Marissa looked up at me. She said, the room just finished cleaning. They're setting up for intubation now. We'll intubate upon arrival to the ICU. All right. So Marissa and I and our respiratory therapist friend packed up and rolled the patient to the ICU with haste. We intubated, gave a few amps of bicarb, set the ventilator on a high rate. His initial ABG right after intubation was a pH of 6.9. Yeesh. But a few hours later, after bicarb and effective ventilations, his ABG was much better. But his mental status was not better. In fact, it took days and days and days until he was able to even follow commands. And even after his rhabdomyolysis had resolved, and once he was extubated, he was still confused and not able to interact with the team, a 40-year-old. And on top of all of the other diagnoses, he had hepatic encephalopathy, and that takes time to resolve. So let's talk about hepatic encephalopathy, what it looks like, how it develops, and how to treat it. I wanted to start by saying this case was complicated by the rhabdomyolysis diagnosis. Not all hepatic encephalopathy patients present like this. Second, great catch on the part of the primary nurse, recognizing that his mental status and respiratory rate were not okay, or something we could just wait for IV fluids to correct. And once again, strong work on the part of my RAP response colleague, Marissa, for recognizing when the patient was no longer compensating and going in the wrong direction. She's seen enough patients crash to know that it's not necessarily a good thing when patients' respiratory rate goes from 50 to 20 acutely. I also wanted to give a shout out to the respiratory therapist who jumped in to help, and the intensivist who listened to our concerns and trusted our judgment that it was time to intubate, even though the oxygen saturation was still fine. This whole case was a beautiful example of interdisciplinary and interdepartmental collaboration. So as to the hepatic encephalopathy, We discussed in the previous liver episodes that the liver plays a critical role in detoxifying substances absorbed from the gut. But in cirrhosis, the liver cannot perform all those functions properly. So this results in the accumulation of neurotoxins like ammonia. Ammonia is produced primarily in the gut by bacterial metabolism of nitrogen-containing substances and protein breakdown. So in a healthy liver, ammonia is converted to urea and excreted, but cirrhosis impairs this conversion, leading to hyperammonemia. Neurotoxins like, I want to butcher these pronunciations, manganese, mercaptans, and phenols, normally metabolized by the liver and excreted in the urine. Those also build up. Hyperammonemia and other neurotoxins induce a state of neuroinflammation, which leads to those neuropsychiatric type symptoms that we often see in hepatic encephalopathy. So, what do patients look or act like when they have hepatic encephalopathy? Well, it is quite a huge spectrum. I have seen it be minor, like just some changes in memory or attention deficits, to major, like coma. Patients who have high levels of these neurotoxins building up can be confused or disoriented. The behavioral changes present on both ends of the spectrum. I've cared for patients who are agitated and combative, who, according to their family, are very mild-mannered and kind at their baseline. And I've also cared for patients who are really depressed, and the family says, this is not like them. They're usually so upbeat and positive. And of course, I've cared for so many patients like this one who's umtunded from all these neurotoxins in their system. Neurotoxins also affect the patient's motor ability, causing rigidity, bradykinesia, and classic symptoms are asterixis, which is like the flapping tremor. It's so important for us as nurses to know and be able to recognize these signs and symptoms of hepatic encephalopathy for two reasons. Number one, to help us be empathetic when the patient may be on the difficult end of the spectrum, poor attention, confused, agitated, irritable, to know that this might not be who they are as a person, that their personality is being altered by buildup of neurotoxins in their blood. And second, so we can anticipate all of the changing symptoms and be able to explain it to the patient and the family with clarity and compassion. The next question is, how do we diagnose hepatic encephalopathy? Hey guys, I just wanted to take a quick break to talk about something that I think is really important, and that is getting certified in your nursing specialty. Not because having the extra letters behind your name make you a better nurse, but because taking the time to deep dive into all that you need to know for your specialty, putting in the study hours, and dedicating yourself to mastering what your patients need you to know how to manage them best, the prep for the exam, is what will make you a better nurse. So whatever specialty you are currently working in, go study for that certification exam. And if you're a critical care nurse, I have something that will help you pass your CCRN. My friend Nick McGowan has an excellent online self-paced CCRN prep course called Critical Care Academy. It is so thorough, and he has broken down everything you need to know into little bite-sized digestible content that he calls micro-learning. Let me tell you, the CCRN is the hardest test I've taken in my entire life. You don't want to go it alone. You want to take this course to ensure that you know your stuff before sitting for the exam. If you'd like to check out his course, you can find it at ccrnacademy.com. And great news, just for being a Rapid Response RN podcast listener, you get 10% off the cost of the course by using the coupon code RAPID10 at checkout. So if you've ever considered getting your CCRN, do it. And let Critical Care Academy help make sure that you will pass. I'll put the link and coupon code in the show notes. Well, I can tell you how not to diagnose it, and that's with an ammonia level. While elevated ammonia levels can often be correlated with symptoms of hepatic encephalopathy, they also don't always. And it's not like you can draw the ammonia and watch that trend to predict the patient's encephalopathy getting better or worse. And I've seen patients with pretty high ammonias who are awake and alert and talking. And I've also cared for patients with ammonia levels that were just barely elevated, but they were very altered. There's definitely some value in just knowing what the ammonia level is to make sure it's not too high and needing dialysis or something. When levels are too high, it can cause cerebral edema. But we can't say, titrate our lactulose to the ammonia level or look at the ammonia to see if the patient's improving. Improvement or decline is much better determined from patient assessment. So, unfortunately, diagnosis of hepatic encephalopathy is based on a combination of things, and there isn't just one test that can tell you, yep, these symptoms are from hepatic encephalopathy. It's kind of a diagnosis of exclusion in the presence of liver failure. We have to pair the clinical presentation with the laboratory findings, and then there are even some neuropsychological tests that can be performed to help guide us towards this diagnosis. We also need to exclude other common causes of encephalopathy, like metabolic encephalopathies or central nervous system infections, drug intoxication or withdrawal, psychiatric disorders, sepsis. So many things can alter the way the patient's behaving, right? And of course, any of those that I listed can also coexist with hepatic encephalopathy, making it extra tricky for you. So, diagnosis is challenging, but not impossible. It's just lots of pieces to put together. The next logical question for us to ask ourselves, once we note the signs and symptoms and diagnostic findings that point towards hepatic encephalopathy, is, well, what the heck caused it? Most commonly, it's going to be non-adherence to the lactulose regimen. But there's also several contributing factors that might precipitate or exacerbate hepatic encephalopathy. So, going back to episode 109 on esophageal varices, gastrointestinal bleeding actually increases the nitrogen load in the gut, and that contributes to elevated ammonia levels. Also, infections can trigger systemic inflammatory responses that worsen encephalopathy symptoms. Electrolyte imbalances like hyponatremia and hypokalemia, those disrupt the cellular functions and exacerbate neurological symptoms. Constipation prolongs that gut transit time, which leads to increased ammonia production in the gut. An excessive dietary protein intake can also worsen ammonia production. Also, renal dysfunction reduces ammonia excretion, further contributing to that hyperammonemia. I'm assuming that it was the renal dysfunction piece that was the culprit for this particular patient that made his hepatic encephalopathy flare, but I don't actually know. His kidneys did take a hit from the rhabdomyolysis, but I don't actually know what was going on for him prior to when his rhabdo developed. He could have been on a bender for a few days, which skewed his electrolytes, or gotten in a car accident, or had a UTI. Again, I'm not always privy to all the information, all the details, being just the rapid response nurse only there for a short amount of time. So we talked about what hepatic encephalopathy looks like, what might cause it, how to diagnose it. So now the next question would be, well, what do we do about it? So managing hepatic encephalopathy involves addressing the underlying cirrhosis, reducing the ammonia load, and correcting whatever precipitating factors might have exacerbated this. So let's start with the primary source of these symptoms, that ammonia buildup. One key strategy to reduce the ammonia is the use of lactulose. It's a non-absorbable disaccharide that acidifies the colon, converting ammonia to ammonium, which is not absorbed. I feel like someone told me long ago that lactulose binds to ammonia and turns it into poop, but that's not actually accurate. Lactulose changes the pH inside the colon, reducing the amount of ammonia that can be produced. But it also makes the patient poop like crazy. In fact, that is the goal. We usually titrate the lactulose dose to how many poops they need per day. We want them to poop. However, you can see why patients may not be motivated to take their lactulose. I mean, who likes having diarrhea? Not me. And neither does your patient. Without a good, solid, convincing explanation, I wouldn't willingly ingest the poop juice either. Another option is rifaximin. It's a non-absorbable antibiotic, which helps reduce the gut ammonia production and then alters the gut microbiome. We might also consult with the dietitian to regulate protein intake because It's crucial to prevent excessive ammonia production. Additionally, correcting electrolyte imbalances, especially sodium and potassium levels, this also is essential in stabilizing the patient's condition and kind of mitigating those encephalopathy symptoms. These combined approaches aim to manage and improve the quality of life for patients with hepatic encephalopathy. Okay, the final thing I want to discuss is the treatment of alcohol withdrawal versus hepatic encephalopathy. I will do a whole episode on alcohol withdrawal, but not today. But because this patient population often becomes altered, it can be difficult to differentiate alcohol withdrawal symptoms from hepatic encephalopathy. And the treatments are completely different and even in opposition to each other. So I wanted just to do a quick summary of the two and just a little bit on how they present differently and their different treatment options. Okay, both conditions cause altered mental status, confusion, agitation, and sleep disturbances. In alcohol withdrawal, symptoms include tremors, not like the asterixis tremors. I would say Google it to see the difference. Hallucinations, anxiety, seizures, and it typically begins either hours to a few days after cessation of alcohol intake. In contrast, the hepatic encephalopathy is characterized by cognitive impairments, personality changes, motor abnormalities like asterixis. While both conditions can lead to severe neurological symptoms, alcohol withdrawal's classic features are autonomic hyperactivity, sweating, tachycardia, and there's always the potential for delirium tremens, which is a life-threatening state of profound agitation and hallucinations. Additionally, the time frame for symptom onset and duration should line up with the patient's last ingestion of alcohol. Symptoms of withdrawal can start surfacing as early as 6 hours after the last drink, and usually begin between 2 and 4 days since the last drink. But symptoms should only last for a few days. So patients who've been in the hospital for 10 days and they're still on a CWIP protocol, I'm thinking the altered mental status at this point is not from alcohol withdrawal. I'm thinking it's from another source. So hepatic encephalopathy, however, does not have a clear onset or duration. It will go on and on until we can get the cirrhosis better managed and reduce the neurotoxins that are affecting the brain's chemistry. And we can look at markers like ammonia level, but it's really not the best predictor. There's other classic cirrhosis symptoms like jaundice or ascites that can kind of help point us towards the diagnosis, especially when you pair those symptoms with the report of the patient hasn't been taking their lactulose or one of the other precipitating factors. Or we've ruled out other causes of altered mental status, and that's how we can differentiate alcohol withdrawal from hepatic encephalopathy. So here's the thing. I'm a huge advocate for evidence-based interventions to prevent seizures in patients withdrawing from alcohol. Things like CIWA protocol, CIWA protocol, that titrates doses of benzodiazepines and nausea medications for patients experiencing alcohol withdrawal symptoms. And I've seen huge benefits from loading doses like prophylactically of medications like phenobarbital to reduce the symptoms and prevent those worst-case scenarios that could worsen the patient's outcome. However, with patients who have hepatic encephalopathy, a hefty dose of phenobarb paired with benzos can really snow these patients because they can't metabolize it quickly at all. So contrast that with someone who's withdrawing from alcohol that has a normal liver, they might not get groggy at all from the phenobarb. But your cirrhosis patients may get absolutely snockered and not be able to participate in their care or suppress their respiratory drive and need intubation, or if already intubated, not be able to be extubated for longer than initially anticipated due to the oversedation from these compounding drugs. So dexmedetomidine is a good drug for hepatic encephalopathy patients, and if they're intubated, propofol rather than benzos and barbiturates. There's so much more to dive in here when it comes to safely managing patients who are in withdrawal, but I will have to save it for another episode. Okay, this is getting very long. Let me summarize. Patients with cirrhosis can't metabolize ammonia, and it starts to build up. Ammonia is a neurotoxin that in large quantities leads to altered mental status. Either end of the spectrum, right? Either they're drowsy, lethargic, and obtunded, or agitated, irritable, and combative. We can treat this by altering the gut's production of ammonia with lactulose and rifaximin. And we can treat the underlying thing, if there is one, that's making the cirrhosis symptoms flare up. We usually try not to give long-acting benzodiazepines and barbiturates to this patient population, but this gets really tricky when patients with hepatic encephalopathy also start to have symptoms of withdrawal from alcohol. There are other options to get them through that couple of days of withdrawal. And like I've said in every liver episode for this liver failure series, cirrhosis is not curable. There are things that we can do to prevent the progression of the disease and treat the symptoms and the complications associated with cirrhosis, but there is no cirrhosis reversal agent. That being said, that doesn't mean there's not hope. Our goal with this patient population is to give them back as much quality of life and independence as possible. And I think when the nurse understands the why behind all of these symptoms and the why behind each intervention, it can help us anticipate what's next, support the patient and the family with education, and better advocate for their best outcome. So I hope that this 4-part series on liver failure has helped you feel more confident in caring for your patients with cirrhosis and ready for all of the complications that might go along with it.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.